I think that this anatomy session is very useful to teach applied anatomy because in medical school sometimes we lose sight of why we're learning the anatomy. We go and you know, we learn about all these tiny little structures and anatomic variants, but none of it's really applicable to what we're doing. And so I think this will be very valuable for students to maybe see past second and third and fourth year medical school and see really why you went to medical school and how you can end up helping people and what your day-to-day life is going to be like eventually when you finish all your training. Orthopedic surgery is a great field that I really enjoy, and I work with many other orthopedic surgeons who really enjoy their job. And the reason being that we are able to take patients out of pain, fix their pain, and generally send them on their way cured of their problem. The field is really quite wide in that there's people that will work 3 or 4 days a week and maybe operate a day a week and have a very, I'll say, kind of relaxed, fairly easy lifestyle. And there's other people that work 6 or 7 days a week with very long days, doing many days of long surgery, and there's really a lot you can do in between. One of the great things about orthopedic surgery is we really do everything from the occiput down to the toes, and so it's an extremely varied field. There's people that do sports medicine, hand surgery, foot and ankle, joint replacement, spine surgery, people that do trauma and take care of elderly hip fractures, or pediatric orthopedists that take care of little babies. And so if you enter the field of orthopedics, there's really still a tremendous variability in what you can end up doing. For me, I find it very rewarding in that I can identify a problem in somebody's spine. They come to my office, they're in terrible pain, or maybe they have a fracture or a tumor, and we come up with a plan and we fix it. And generally we can send them on their way and they can live a happy life. The path to orthopedic surgery, it's generally a very competitive specialty, so people really do need to do well in medical school and focus on doing well on the boards. Generally, most people who want to do orthopedics know fairly early in medical school, and the reason that probably is that many people will do research and really try to build up their CV, having some experience in ortho, knowing some orthopedic surgeons, focusing on their grades and boards, and then really working hard to match into orthopedics. The match rate hovers at 70 or 80%, although we've done very well at Brown at having people match. And so people really need to be focused on their goal of achieving orthopedics. With that being said, there are people that are able to choose late and still successfully match. The training for orthopedic surgery is 5 years of residency training after medical school. Essentially 100% of people do a fellowship. So I did a spine fellowship. I'm spine fellowship trained, meaning I actually did 7 years of training, so I also did a trauma fellowship. People that do spine surgery also can do a neurosurgery residency, which is 7 years. And then some of them will even do a fellowship, so it's 8 years of training. The practice of spine surgery is divided between orthopedic surgeons and neurosurgeons, and they really have the same scope of practice. It's just a different training to get there. The anterior cervical spine approach is most commonly used for decompressing pinched nerves or spinal cord impingement that could cause cervical myelopathy. It's a very commonly used procedure in the United States. Most commonly, orthopedic surgeons will take a left-sided anterior approach, and neurosurgeons often take a right-sided anterior approach. This is done due to the more predictable path of the recurrent laryngeal nerve on the left. However, many studies have shown that there's actually no difference in injury of the recurrent laryngeal nerve, whether you go right or left, as long as the surgeon is careful to protect it during the approach. Oftentimes we'll use a transverse approach to access the cervical spine. As you see that this cadaver has had multiple other dissections performed. And what we will do, we would not do this in the operating room, but for the sake of being able to visualize, we will remove the skin tissue so that we can see all of the deep structures. So generally, this is a fairly small area. You see there's only approximately 4 finger breadths between the mandible and the clavicle. Most commonly, we're approximately 3 finger breadths above the clavicle to access the C5-6 disc, which is the most common disc that has pathology. Usually people present with arm pain from a herniated disc. So what we'll do is we'll make a transverse incision approximately 5 or 6 centimeters long, just through the skin first, from here just to the midline. I'll show you the deep structures. Here you see the sternocleidomastoid. Just deep to the sternocleidomastoid muscle, you have the carotid sheath, and the carotid artery has already been dissected here. This is clearly a structure that we're very careful to avoid injury to when we're performing this surgery. And the intramuscular and intranervous and avascular plane is just medial to the carotid sheath and just lateral to the esophagus and the trachea. Between these two structures is essentially a direct path to the cervical spine. For the sake of this dissection, I'm going to remove some of the medial structures so that we can see the cervical spine more easily. Again, clearly would not do this in the operating room, but what we would do is instead retract them medially so that they were out of the way. So what you see here, again, is the carotid artery, which is coming off just to the left of the patient's spine. There's clearly one also off to the right that would be out of the surgical field. And you see here there's this fascial layer directly overlying the cervical spine. What we do in the operating room is we incise this layer. We usually use electrocautery to help minimize bleeding. Then we see the longus colli muscles here on each side. The longus colli muscles are elevated off of the anterior cervical spine to access the area of the disc space. Once you have a submuscular plane or a subperiosteal plane, you're essentially directly on bone and disc. This patient has a very arthritic spine, so it's very difficult to access the disc space because they're very collapsed. What I'm doing is trying to feel where the disc space is. In the operating room, we'll use a radiograph or an x-ray to see where the disc is. What we'll do is try to remove the osteophytes, remove some of the osteophytes to be able to see where the delineation between the disc and the bone is. Spine surgery procedures tend to be more lengthy than some other surgeries. One reason is clearly we have to be very careful around the soft tissue structures of the neck, but also once we get down toward the spinal cord, you have to be very careful not to cause any injury to the spinal cord or minimal manipulation of the neural elements. This patient has calcified discs, which is fairly common in elderly patients, but you see this knife starting to enter the disc space. This is a very collapsed disc, arthritic, as tends to happen with age. Often these procedures are performed in younger patients due to the fact that manipulating the anterior airway structures and the esophagus leads to swallowing problems in elderly patients that younger patients just tend not to have. Removing the bone in the cervical spine is known as a corpectomy. You can remove the vertebral body to access the spinal cord itself with excellent visualization of the spinal cord and the nerve roots which come off of the spinal cord. This is an excellent view of cervical disc, the cervical body with the cancellous bone, and then another cervical disc. During the procedure, if you stay in the midline, you're safe from the vertebral arteries, which run just lateral to each vertebral body. If the surgeon moves too far laterally, there's some risk to the vertebral artery. To be extremely careful of that. It's very hard to control bleeding from a vertebral artery if there is an injury intraoperatively. Often you have to have the interventional radiologist control it even because it often cannot be accessed safely from the front. One reason being that the nerve runs right near the vertebral artery. If you try to tie off the artery, there's some risk you could tie off the nerve at the same time. Clearly would not hammer on the front of the cervical spine than an anesthetized patient the same way. This is now the posterior aspect of the vertebral body. You see how now the structure is soft. This is the posterior longitudinal ligament. This is now, we've now reached, you see that you have bone all the way back. The disc has been resected. Bone all the way back, disc has been resected, and this soft structure here, this is the posterior longitudinal ligament. Posterior longitudinal ligament is removed when we were trying to decompress the spinal cord for compressive pathology that can cause myelopathy. Myelopathy is dysfunction of the spinal cord. It's hallmarked by difficulty with coordination, walking, and weakness. It's often irreversible. Therefore, when it becomes progressive, the patient often wants to have surgery to try to prevent any further progression. As I said, it tends to be permanent. And it does progress in a stepwise fashion, meaning that if a patient comes in and has lost the ability to walk due to such weakness or lack of coordination, they often are unable to get it back, even with surgery. Therefore, you want to operate early on this particular problem. You'll see here she has the esophagus and trachea retracted medially. This is further medial than will be retracted in a living patient due to the fact that we have bisected it. You see here, this is a vertebra. This is the C5 vertebra. The C5-6 disc is here and has been removed. The C6 vertebral body has also now been completely removed with a corpectomy. C6-7 disc is removed and the C7 vertebral body is here. Carotid artery, the entirety of the carotid sheath and the sternocleidomastoid are off lateral to the operative field. Deep posterior longitudinal ligament has been resected, and the dura is here with the spinal cord lying within the dura. The nerve roots come off on each side. C6 nerve root comes here and tends to be pinched by a C5-6 disc. Therefore, a C5-6 discectomy would be able to remove pressure upon the C6 nerve root and would alleviate arm pain and weakness due to a disc herniation. The recovery time is quite rapid from these surgeries with a simple discectomy. Generally, the patients will stay overnight one night, have relatively minimal pain, and be back to relatively normal activity within just 2 weeks or so once the incision is healed. Most common problems are some swallowing difficulty due to retraction of the esophagus or possible denervation of some of the esophageal nerves. And some airway issues are possible but are quite uncommon. The anterior lumbar approach is less commonly used. However, it can be very effective for achieving a fusion in the anterior lumbar spine and for propping up the disc space. Generally, this is a retroperitoneal approach. Formerly, individuals used to use a transperitoneal approach where they moved the bowel out of the way but went through the peritoneum. Now we've found approaches that can actually go extraperitoneal around the peritoneal cavity without violating the peritoneum and pulling the abdominal contents to the side. Generally, the approach is most commonly a left-sided vertical approach. However, there's many minimally invasive approaches or even a fan and steel incision similar to a C-section that can be done for L5-S1 disc space. Generally, we'll make the approach in a vertical fashion here, and we'll come down to the rectus sheath. We'll make an incision in the rectus sheath up to the arcuate line or even higher, depending on the level of the disc that needs to be fused. And here in this cadaver, the peritoneum's already been violated. We generally stay retroperitoneal, meaning that although we start in front of the peritoneum, seeing that we're extraperitoneal, we're able to stay actually in the retroperitoneum. This is retroperitoneal fat. This is how you know you're in the correct plane. Let's go that way. You see this bright yellow fat in the absence of bowel, you know that you're in the retroperitoneum. You see here these muscle fibers coming. This is either the quadratus lumborum or the psoas muscle. As we get a little deeper, you'll see these large longitudinal fibers that represent the psoas muscle. This is the psoas, large tubular muscle, filet mignon in a cow. We do not violate the psoas muscle in this surgery in a living patient. Once we've retracted the peritoneal structures medially, you see that the L5-S1 disc is here. Generally, the 5-1 disc sits below the bifurcation of the iliac artery and vein. In this cadaver, we're unable to see. However, the iliac vein and artery on the right side would come off, down on the right. The other would come off to the left, and we would work between them. The 5-1 disc being here, we could perform our discectomy. The posterior approach to lumbar spine is very commonly used in spine surgery, most commonly used for disc herniations or spinal stenosis. We also use it for fixing fractures, decompressing tumors, and it's really a very versatile approach to any operation in the lumbar spine. You can also access the thoracic spine and cervical spine from the posterior approach. This is generally a midline approach. We commonly use an open surgical approach, meaning that we will do a longitudinal midline incision. However, Recently, there's many people who are doing minimally invasive or even percutaneous operations through very small incisions. Generally, in an alive patient, we'll use one small transverse incision and very carefully respect the muscle using a subperiosteal dissection. In this cadaver, we will open the skin. This is an extensile approach to the lumbar spine. Clearly, in a living patient, we would not be elevating the muscles off. Instead, we generally use electrocautery to use a subperiosteal dissection to carefully elevate the muscles off without violating them. The posterior approach, as I said, is extensile. It can be done all the way from the sacrum up to the occiput, and patients will commonly get long segment procedures all the way from the thoracic to the lumbar spine. This here is a bit challenging to see the anatomy. But you see that the ilium and the posterior superior iliac spine is here. This is the segment where we'll actually place screws into the ilium to attach the spine to the pelvis in patients with spinal deformity or other spinal instability. The bony sacrum is here. And then the lumbar spine is here. This patient has a small amount of scoliosis. You see a small curvature here. The facet joints allow for mobility in the lumbar spine. So there's a facet joint here, there's this bulbous structure, it's a facet joint here and here. If you're doing a spinal fusion, meaning you're trying to get the spine not to move anymore and putting screws and rods in, you'll violate these facet joints. In procedures where you're only doing a decompressive procedure, you try to respect the facet joints and not violate the facet capsule so that it remains a healthy joint. Generally in the posterior approach, the most common operation would be just a discectomy, in which we would take a very small area of bone and access the nerves to take a disc out to help people with leg pain from a disc herniation. In this dissection, it's going to be easier to see if we perform what's called a laminectomy and remove the lamina. So we've got these instruments that very carefully protect the neural elements when we take the bone off. They kind of it's a footed biting instrument so that you can put a nice smooth surface on the nerves and then bite the bone, but we don't have that here. So this is why spine surgery is difficult, though. You have to remove a very hard bone over a very delicate and important structure that often when damaged does not recover. And so you have to be very careful. The other issue with cadavers is that they don't have any cerebrospinal fluid, and so the dura collapses, and it's just this tube, you know, and it's not very gratifying to see it. As compared to in the operating room, you see the dural tube pulsating with the patient's respirations and the flow of the CSF, and it's kind of very exciting. You see, you know, spinal cord, and when you're in the thoracic and cervical spine, and here we just see a collapsed tube that looks empty. The goal of a laminectomy is to remove the bone which overlies the dural tube. This is the level of L5 and L4. So this is the cauda equina, which sits inside the dura. As I mentioned, in a cadaver, the dural tube tends to be deflated. The cerebrospinal fluid has leaked out after the patient passed away. However, in a living patient, the dural tube is inflated and actually has pulsations with the respirations of the patient. The goal of the laminectomy is to take all the pressure off of the dura. Patients that have spinal stenosis or a herniated disc can have symptoms such as neurogenic claudication or leg pain or leg numbness or weakness because the nerves get pinched. Once you remove the bone, generally the dura and the nerves float back and they have plenty of room. Here you see the central dural tube and a nerve root coming off here, which they come off just below the pedicle at each level. The discs are just above the pedicle, so there's a disc here, this white structure. When the disc herniates, it can pinch the nerve right here, just medial to the pedicle, and cause patients to have a tremendous amount of pain. When we do a discectomy, we come in, retract the dural tube medially, remove the fragment of the disc which is pushing upon the nerve, and then generally close the wound. Even a patient with a multi-level laminectomy, they'll often ask if there's a problem that their spinal cord, or in this case the cauda equina, is exposed, and the answer is no. The muscle heals over it, and there's really no risk from being hit in the back and having any sort of spinal cord injury. When we place pedicle screws to fixate the spine or stabilize the spine, the bony pedicle is here. We generally place the pedicle screw in this orientation, which allows a very strong and safe column of bone to place the screw. These can be placed at every level, all the way from the cervical spine down to the sacrum, and even into the ilium. We have safe columns of bone where we place screws. For ankylosing spondylitis, the most common thing we do for ankylosing spondylitis is treat fractures. When patients have ankylosing spondylitis, their bone is extremely stiff, and essentially it's brittle, and the vertebrae heal together, so there's no discs. Therefore, when these patients fall on their back, they can get an extension injury and essentially crack the spine open like this, because when patients that have open discs, when they fall on their back, the spine is flexible. It relaxes, lays down, then it goes back. These patients have no recoil. It's like a toothpick. It can't bend, and so it breaks, and when that happens, extremely unstable spine fracture. And 95% of the cases we do on ankylosing spondylitis patients are fracture fixation with screws and rods. Rarely we also do deformity operations in patients with ankylosing spondylitis because they become very kyphotic, and you have to do what's called an osteotomy, take a wedge of bone out and close the wedge down and help them stand up straight. But with the advent of anti-rheumatoid medications and new drugs that are specifically for ankylosing spondylitis, we're actually seeing less and less in practice of patients with severe end-stage ankylosing spondylitis. The other interesting thing about them, I had a patient who had a fracture who had ankylosis all the way from his occiput to his sacrum. He was fused. And I asked him if he felt like he was stiff in life and how did he live, and he said, "No, I'm fine." You know, he just had been that way so long, he didn't even notice that he had zero mobility to his entire spine. There are other approaches to the lumbar spine, one of which is a lateral approach. We will do minimally invasive lateral approaches through a very small incision here on the flank. We can access the disc space from a small minimally invasive approach, and with lighted retractors can perform a discectomy and a fusion through a tiny 3 to 4 centimeter incision. All right, for this section I'll be going over some of the osseous anatomy of the skeleton and the spine in particular. I'll start at the top and move my way down. So for the cervical spine, the anterior cervical approach is generally useful from approximately C3 to T1, and that's because of limitations with the mandible and the clavicle and sternum, and there's only so much area we can get. For example, if the thoracic ribs, sternum manubrium are in the way to access the lower thoracic spine, you know, the skull and mandible are in the way generally for C1 and C2. Therefore, for a standard anterior cervical approach, we'll come in here to approach the bone and disc in the anterior cervical spine. Most of the pathology in the spine emanates from the disc. Disc degeneration can cause spinal stenosis or disc herniations that can cause people pain and dysfunction. When we access the front of the cervical spine, you have to keep aware that the vertebral artery runs in the foramen transversarium, which is just lateral to the spine, so you have to be very careful about your anatomic orientation to stay in the midline, which seems like it should be easy, but there are times if a patient's head is a little bit turned on the table, or they have trauma or a tumor or severe degenerative disease, it may be hard to actually orient yourself to right where the midline structures are. But that's imperative for patient safety. So for some bony anatomy, you see you have the vertebra here in the middle, what's called the uncinate process, which is essentially a joint between the vertebra above and the vertebra below, the spinous process, and then the foramen transversarium where the vertebral artery runs. As we move our way down, you see the relatively stiff thoracic cage, which is a kyphotic segment. Kyphotic meaning that it's essentially tilted forward. The cervical spine is lordotic, thoracic spine is kyphotic and very stiff. Generally, there's less pathology in the thoracic spine, probably because it's less mobile, and so you don't have as much degeneration of the discs. However, things such as tumor and trauma can cause very severe problems in the thoracic spine because the spinal cord to canal ratio is very small. And so there's very little ability for the spinal cord to move if there's any sort of trauma to that area, and people get thoracic spinal cord injuries very commonly with high-speed trauma. In the lumbar spine, the anterior approaches are a little bit less common, but are done if you want to do a complete discectomy. The reason they are not done as often is that an anterior approach in the lumbar spine is not generally useful for decompressing the neural elements. So it's usually more commonly done for back pain, and seeing that back pain operations are not often successful, we don't do them very often. It's only for very specific things such as spondylolisthesis, which is when two vertebrae slip forward, and if you want to stabilize that segment. In terms of the posterior anatomy, posterior approaches are more commonly performed surgically. We do surgery all the way from the occiput down to the sacrum. Upper cervical, occipital, C1c2 anatomy is very complex. It's very difficult to operate on safely, largely because the vertebral artery comes out, again, of the foramen transversarium, wraps around the top of the C1 ring before going into the base of the skull. And so when doing decompressions or instrumentation of the top of the cervical spine, there's a lot of risk to the structures. Most commonly, if you're doing a posterior cervical operation, it's either for trauma and you're stabilizing the spine with screws and rods, or a decompression where you do a laminectomy and remove the lamina. So a laminectomy is any time you remove the lamina to take the pressure off the spinal cord and generally let it drift back. Again, you do have to be careful recognizing the vertebral artery sits just in the front, so whatever you're doing, you always have to have a three-dimensional understanding that the spinal cord is just in front of you and the vertebral artery is just out laterally. And those are the two main structures that are at any risk. As you come down to the thoracic spine, you have the bony thoracic spine, and again, it's a very stiff segment and relatively uncommon in terms of operations that we do as compared to the cervical or lumbar spine. In the lumbar spine, most common operation would be a diskectomy, where you take a very small amount of bone away, called a laminotomy, and just make a small hole in the lamina to safely access the dura and the nerve root, move it medially, and then perform a diskectomy. The bony sacrum is attached to the pelvis, and we will do stabilization operations to sometimes stabilize the lower spine to the pelvis in things such as deformity or serious trauma or tumor. We do have ways to instrument the spine all the way from the top to the bottom, and there's many techniques, whether it's through what's called a sublaminar wiring, where you pass a wire under the lamina, to pedicle screws that go into the pedicle and avoid the nerves, or up in the cervical spine, something called a lateral mass screw, where the screw is placed within this bony column called the lateral mass. The muscular and the ligament anatomy is very important in the spine. We worry a little bit less about the muscles as opposed to many other types of orthopedic procedures, because generally what we're doing is just a subperiosteal dissection to move the paraspinal musculature off of the spine. There's really no other applicable anatomy in terms of muscles in the spine for surgery. In terms of the ligaments, as you come through the spine, you have the supraspinous ligament in the back that's generally divided when we're doing surgery. The interspinous ligament, which sits between the spinous processes, again, is often resected when doing a laminectomy, and patients often can do just fine without these two ligaments as long as the other structures are intact. As you get deeper, the facet capsules are another stabilizing structure that's very important that we try not to violate unless we're doing a spinal fusion, in that we want to allow that to help maintain the integrity of the spine. But we will resect the facet capsule if we're going to fuse the level. Fusion is when you, in some way, stabilize two vertebrae together and try to get them to actually heal together with bone. As you get deeper, the ligamentum flavum sits just under the lamina, and it's a very common cause of spinal stenosis, and often has to be resected if it's causing pinching in the nerves. As you get under the ligamentum flavum, the dura is there. When you move the dura out of the way, then the posterior longitudinal ligament will sit at just the very posterior aspect of the vertebral body. And in cervical approaches in particular, you have to actually sometimes remove the posterior longitudinal ligament to access the spinal cord. And then sitting right in the front of the spine is the anterior longitudinal ligament. So a laminotomy for discectomy can be done through a small tubular retractor in a minimally invasive fashion. The way I perform is actually through an open approach, but the incision is only 3.5 centimeters, so it's still quite a minimally invasive approach, and people often go home the same day or the next day. You incise the skin and you come down directly onto the lamina here. Generally, a laminotomy includes a small resection, just a few millimeters of the inferior portion of the superior lamina. So if we were going to be doing an L4-5 discectomy or laminotomy, you take 3 or 4 millimeters or maybe a little bit more of the lamina of L4. You find the dura safely, you work your way down, then you take the 3 or 4 millimeters of the L5 lamina, and you basically create what's called a keyhole. It's basically a perfectly round area right here. So you just remove some of the lamina. You stay away from the facet joint, you stay away from the pars intra-articularis, and you generally don't have to take the interspinous ligament or the spinous processes. When performing a discectomy, generally, the reason to perform a discectomy is to take pressure off of the nerve root. So in L4-5 discectomy, the goal is to take pressure off the L5 nerve root in a standard disc herniation. The L5 nerve root comes out just under the L5 pedicle here and comes out anteriorly down to form the sciatic nerve. The orientation of the nerves as they come as related to the vertebra can be very confusing for medical students. The reason being that it's different in the cervical spine as compared to the thoracic and lumbar spine. The reason that is that there are not an equivalent number of nerves as there are to vertebra. Therefore, the C1 nerve root comes out above C1. The C2 nerve root comes out above C2 pedicle. But as you come down, you'll find that at C7, the C7 nerve root comes out above, but the C8 nerve root comes out below. Then in the thoracic spine, T1 comes out below T1. And from the thoracolumbar spine, then it's very straightforward in that, as I had stated, at L5, the L5 nerve root comes out just below the L5 pedicle. And that is because there's an unequal number of nerve roots to vertebra. A C5-6 discectomy is generally intended to decompress the C6 nerve root and take pressure off of the C6 nerve root. And that is similar to an L4-5 discectomy, for example, where you take pressure off the L5 nerve root. So generally, in surgery, we are decompressing the nerve of the vertebra, which is most caudal. This is different from the cervical and the lumbar spine because generally in the lumbar spine, the disc herniation will affect the traversing nerve root, which is a nerve root that is still within the spinal canal. While in the cervical spine, the discs tend to be more lateral and affect the exiting nerve root.